Все, спасибо. Good morning for everyone. I hope you have already waked up. And today is Friday and our last lecture according to the tumors and tumor-like diseases or formations in maxillofacial area. Tumor, also called neoplasm, a mass of abnormal tissue that arises without an obvious course from pre-existing body cells, has no purposeful function, and it's characterized by a tendency to independent and unrestrained growth. Tumors are quite different from inflammatory or other swellings because the cells in tumor are abnormal in appearance and other characteristics. Abnormal cells, the kind that generally make up tumors, differ from normal cells in having undergone one or more of the following alterations. And hypertrophy, or increased in the size of individual cells. This feature is occasionally encountered in tumors but occurs commonly in other conditions. Hyperplasia, or increase in number of cells within a given zone. In some instances, it may constitute the only creation of tumor formation. And third, it will be anaplasia, or regression of physical characteristic of cells toward a more primitive or undifferentiated type. This is an almost constant feature of malignant tumors, though it occurs in other instances both in health and in disease. In some instances, the cells of the tumor are normal in appearance. The differences between them and normal body cells can be discerned only with some difficulty. Such tumors are more often benign than not. Other tumors are composed of cells that appear different from normal adult types in size, shape, and structure. They usually belong to tumors that are malignant. Such cells may be bizarre in form or may be arranged in distort manner. In more extreme cases, the cells of malignant tumor are described as primitive or undifferentiated because they have lost appearance and functions of the particular type of specialized cells that was their predecessor. As a rule, the less differentiated malignant tumor cells are, and the more quickly the tumor may be expected to grow. Malignancy refers to the ability of a tumor ultimately to cause death. Any tumor, either benign or malignant in type, may produce death by local effects if it's appropriately situated. The common and more specific definition of malignancy implies the inherent tendency of the tumor cells to metastase. I hope you understand what does it mean. It's invade of the body widely and become disseminated by subtle means, and eventually to kill the patient unless all malignant cells can be eradicated. And here on this slide you can see different types of classification. Of course, it's a basic classification. We can say that tumors can be benign and malignant. And in stomatology, our basic classification is odontogenic and non-odontogenic tumors. Odontogenic, that is tumor which originates from odontogenic tissues. And here you can see classification of odontogenic and non-odontogenic tumors. According to the symptoms of common symptoms of tumors, first let's talk about metastasis. It's a symptom of malignant tumors, of course, and metastasis is thus an outstanding characteristic of malignancy. Metastasis is tendency of tumor cells to be carried from their site of origin by way of circulatory system and other channels which may eventually establish these cells in almost every tissue and organ of the body. In contrast, the cells of benign tumor invariably remain in contact with each other in one solid mass centered on the site of origin. Because of the physical continuity of benign tumor cells, they may be removed completely by surgery if the location is suitable. But the dissemination of malignant cells, each one individually processing those cell division, the ability to give rise to new tumors in a new and distant sites requires complete eradication by a single surgical procedure in all but the earliest period of the growth. A mass of tumor cells usually constitutes a definitive localized swelling that, if it occurs on a near surface of the body, can be felt as a lump. Deeply placed tumors, however, may not be palpable. Some tumors, and particularly malignant ones, may appear as ulcers, hardened cracks of the fissures, wart-like projections, or diffuse, ill-defended infiltration of what appears to be an otherwise normal organ or tissues. Pain is a available symptom of tumors. It most commonly results from the growing tumor processing on adjacent nerve tracts. In their early stages, all tumors tend to be painless, and those that grow to a large size without interfering with the local functions may remain painless. Eventually, however, most malignant tumors cause pain by the direct invasion of the nerves or the destruction of the bone. All benign tumors tend to remain localized at the sites of the origin. Many benign tumors are enclosed by a capsule consisting of connective tissue derived from the structures immediately surrounding the tumor. Well-encapsulated tumors are not anchored to their surrounding tissues. These benign tumors enlarged by a gradual build-up, pushing aside the adjacent tissues without involving them intimately. Malignant tumors, by contrast, don't usually possess a capsule. They invade the surrounding tissues, making surgical removal more difficult and risky. A benign tumor may undergo malignant transformation, but the course of such change is unknown. It's also possible for a malignant tumor to remain quintessence mimicking a benign one clinically for a long time. The regression of malignant tumors to benign is unknown. Tumors in maxillofacial region are located in the soft and hard tissues. Those located in facial skeleton are rare and can be of dental origin, odontogenic as I said, or rarest from bony tissues, osteogenic. No matter whether they are benign or malignant, clinically they are often symptomless for a long time. Only rarely do they cause pain. Even on X-ray films, their appearance is very uniform. Most of them present as mono or polycystic lesions. Even the distinction of whether these lesions are well delineated or not doesn't help to determine whether a tumor is benign or malignant. Also, examinations with computed tomography or MRI gives much more precise information about the contours and delineation of these lesions. In most of the cases, it's not possible to establish a diagnosis. This can only be done through a biopsy and histological examination. These biopsies should always be open biopsies to receive sufficient material in quantity and quality. This is important because many benign or malignant tumors can present with histologically similar pictures. This is true for odontogenic tumors. Also, it may be difficult to differentiate between fibrous dysplasia or ossifying fibroma, osteoblastoma and osteosarcoma, or desmoplastic fibroma and fibrosarcoma. A very close cooperation between the clinical pathology a very close cooperation between the clinician, pathologists, and radiologists is mandatory to receive an exact diagnosis. The pathologists need all clinical and radiologic information because tumors that are histologically similar may have different diagnoses according to their different anatomic locations. Correct treatment plan can, of course, only to establish with a precise preoperative diagnosis. Odontogenic tumors and tumor-like lesions of dental origin are less common than those of osseous origin. Most reflect a state out of the development of the tooth. Because epithelial and mesenchymal tissues are involved in the formation of the tooth bud, both components can be involved in formation of odontogenic tumors. Most odontogenic tumors are benign, and some are not even tumors but rather tumor-like lesions, so hemangiomas, such as all odontomas. Therefore, most are clinically as well as radiologically and histologically well delineated and can be treated with curettage, enucleation, or sometimes fenestration. Their radiologic appearance is very uniform and often resembles follicular cysts. Benign epithelial odontogenic tumors of the jaw. Ameloblastomas. Ameloblastoma is benign tumor located exclusively in the jaws. It has a distinctive histological appearance, and the diagnostic cells are columnar basal staining cells arranged in a polysaccharide pattern along the basement membrane. The name of this tumor derives from the fact that the cells closely resemble ameloblasts and are felt to be the cells of origin. Ameloblastomas are divided into three fairly distinct types: solid, cystic, and peripheral. And let's have a few words about each of them. Solid ameloblastomas. These tumors present with various histological patterns, including follicular, plexiform, and granular cells variants. They are thought to be of histological interest only and don't affect the treatment or prognosis. At one time, the granular cells ameloblastoma was believed to be a more aggressive variant, but that is no longer the case. These tumors are benign but locally aggressive and can occasionally metastase. They most commonly occur in the mandible, particularly around the angle of the mandible. In most studies, they are the second commonest odontogenic lesions after odontomas. Imaging of these lesions is normally initiated with plain radiography, such as panorex radiographs, reinforced by computed tomography scans when there is any questions of lingual or buccal expression or perforation. Enucleation has been traditionally associated with the recurrence rate of the and more aggressive treatment must be performed. Histologically, cells have been shown to be present several millimeters from the radiographical margin of the lesion, and this has led to a general principle that surgery should be performed with 1 centimeter bony margins around the radiographical limits of the lesions and single tissue plane clearance in the case of the soft tissue extension. For example, supraperiosteal dissection. Sometimes this can be carried out with a margin mandibulectomy, but often a submental resection is required. The infection is unusual for ameloblastoma, and the inferior alveolar nerve is often sacrificed and can be reconstructed with a nerve graft if indicated. And on this X-ray, panoramic X-ray, you can see solid ameloblastoma in the angle and ramus of the mandible. It's too big, and after enucleation we have to do splints on the jaw to avoid pathological fracture of the mandible. Next one is a solid plexiform ameloblastoma, and as you can see on this slide, we can see it on maxilla, and in the maxilla, wide margins can result in invasion of the sinus, nasal cavity, orbit, or infratemporal fossa. Immediate techniques such as aggressive local curettage followed by liquid nitrogen cryotherapy have also been advocated. This technique has been associated with high levels of success and don't deserve consideration in treatment planning. Maxillary ameloblastomas, although rare, are often more troublesome than mandibular lesions. Histologically, they are identical and behave similarly, except that their pathways to infiltrate are more than numerous. Involvement of the maxillary sinus and nasal cavity tends to occur fairly early and spread through the posterior wall of the maxilla into the pterygium maxillary space also occur. Reconstruction of this area is normally by means of the skin graft and prosthetic obturator. Also, in some centers, autogenous reconstruction of the palate with microvascular-free flaps has been used. Ultimately, implants would be placed in any bone graft for the final prosthetic reconstruction. Cystic ameloblastomas. This is a difficult diagnosis because many ameloblastomas have cystic components within them, and of course only histological examination can truly say us what type of ameloblastoma is this. And as you can see, cystic ameloblastoma is less in size than other two types. And on previous slide, you can see that solid plexiform ameloblastoma is more aggressive ameloblastoma, and on this particular case, you can see that ameloblastoma arises inside all of the mandible, and it's quite difficult to remove it without any resection of mandible. And of course, in future we have to do some obturators for patient who have normal chewing function. And the last one, it's a peripheral ameloblastoma, and of course on its name you can understand that it grows outside and less severe process than all other ameloblastomas which grows inside the bone. The peripheral ameloblastoma is also known as extraosseous ameloblastoma or soft tissue ameloblastoma. In general, it occurs in the gingiva and bone involvement is insignificant. The peripheral ameloblastoma is a painless, sessile, firm, exophytic growth that is usually relatively smooth or granular. It may also have a warty appearance. They are generally believed to represent 10% of all ameloblastomas diagnosed. And here on these photos you can see some tumor in the gingiva, lower jaw, and no specific clinical or radiographical appearance we can see, and of course only after histological examination we can put diagnose. Odontogenic fibroma is a benign odontogenic tumor that may arise centrally in the jaw bones or peripherally on the gingiva. Central odontogenic fibroma on clinical examination usually presents as a non-tender swelling showing cortical expansion. However, root displacement and the root resorption have also been reported in cases where lesions are more severe. And of course, there are a lot of different types of odontogenic fibroma, and here you can see X-ray and clinical picture of an intraosseous or central odontogenic fibroma, and microscopic view. Histologically, the most consistent feature is a tumor composed predominantly of the mature collagen fibers with numerous interpersed fibroblasts. The presence of small nests and or stands of inactive odontogenic epithelium is a very reliable feature. And here you can see histopathological report of central odontogenic fibroma, and we can see mature collagen fibers and odontogenic epithelium. The peripheral odontogenic fibroma is a reactive lesion characterized by soft tissue growth nodule and is probably originated from the periodontal ligament fibers. It can be sessile or pedunculated, and its appearance may vary from pink to red. Red is usually ulcerated and forms smooth to irregular surfaces. Mineralization focuses are commonly observed present in its cementum-like bone or dystrophic calcification arrangement. And here you can see clinical pictures of odontogenic fibroma of peripheral type. Odontomas, it's most interest of all stomatologists and surgeons in odontomas. Odontomas are most common type of odontogenic tumors. They are included under the benign calcified odontogenic tumors. Odontomas are basically classified into two types, complex and compound. Generally, they are asymptomatic. Occasionally, signs and symptoms relating to their presence do occur. So, management depends upon the early diagnosis, histopathological examination, and excision of these tissues. Odontomas, by definition alone, refers to any tumors of odontogenic origin. This is because odontomas results from the growth of completely differentiated epithelial and mesenchymal cells that give rise to ameloblasts and odontoblasts. These cells in turn form variable amounts of enamel and dentin and pulpal tissues of the odontoma. This enamel and dentin were usually laid down in abnormal pattern because the organization of odontogenic cells failed to reach the normal state of the morphodifferentiation. So they are considered as a developmental anomalies rather than true neoplasm. The etiology behind odontomas remains unknown. It has been related to various pathological conditions like local trauma, inflammatory process, or infectious process, mature ameloblasts. One of the most common classification is given by the World Health Organization. Several types lesions containing enamel and dentin of normal appearance are defined in the classification. There follows ameloblastic fibro-odontoma, odontoameloblastoma, complex odontoma, and compound one. And let's talk about last two ones. Complex odontomas, when calcified dentin tissues are simply arranged as a regular mass, bearing no morphologic similarity to rudimentary teeth. And compound odontoma, it's a composed of all odontogenic tissues in orderly pattern that results in many teeth-like structures but without morphological resemblance to normal teeth. And I will show you radiological or X-rays with different types of odontomas, and here you can see compound odontoma, and you can see some shapes of teeth, but they are not completely in the right order. And of course, this odontomas case erupt in the oral cavity, but we can't use, or patients can't use these teeth for chewing because they are abnormal. Majority of odontomas can be detected by the routine radiography, but may cause difficulty in identification due to lack of calcification. A differential diagnosis is usually made through comparison of the degree of morphodifferentiation and histodifferentiation of the dental hard tissue. A visual examination of the lesions cannot by itself define the differences between the complex and compound types, because the odontomas are usually in the bone structures and don't show outward signs such an expansion of the bone, even in rare instances in which odontomas are wrapped into the oral cavity. In comparison to visual examination and manual palpation, radiographic examination seems to be the most effective clinical method of discrimination between two types. In case of compound odontoma, radiographic image show comparatively well-organized malformed teeth or tooth-like structures, usually in radiolucent cyst-like lesion. A complex odontoma shows an irregular shaped oval radiopacity, usually surrounded by a well-defined thin radiolucent zone. And you can see it on the next slide. It's a histological appearance of compound odontoma, and we can see different tissues of the tooth, even dental pulp. And this is complex odontoma, and you can see they are quite right. Order position of tissues and irregularity of different types of cells and tissues. And here on this slide you can see X-ray of complex odontoma. It's some bone-like structures of hard tissues of the tooth. It can be with soft tissues of the tooth, different compositions and sizes. And as you can see, mostly we can find odontomas in the lower jaw. Odontomas are easily enucleated, and adjacent teeth that may have been displaced are seldom harmed by the surgical excision because they are usually separated by a septum of the bone. But sometimes, due to extension of odontomas, the adjacent tooth may be disturbed by removal, of course. And here on this slide you can see removed odontomas. It's a complex one. You can see different tooth-like structures or hard tissues of the tooth. And that is all about odontogenic tumors, and let's talk about non-odontogenic tumors. And as you know, non-odontogenic tumors can arise from different tissues of the body, and we can say about epithelial region, connective tissue region, vascular region, nerve, muscle, bone, and tumor or tumor of the bone region. And let's see about benign vascular tumors. Hemangiomas are formed due to the failure of differentiation in the early stages of embryogenesis. However, vascular malformations are caused due to disturbance in the late stages of androgenesis, resulting in the persistence of embryonic arteriovenous anastomosis. The shunt from high pressure to lower pressure compartment can produce a pulsating mass and characteristic brood. The line emerging from the shunt becomes delimited and thickened and increased from rate counts for observed delineation of the arteries. Histologically, we can see different types of hemangiomas. And as you can see, it can be hemangioma or blood-containing lesions, lymphangioma, lymph-containing lesions, and when it's hemangioma, we can say about arterial and venous types. According to the size of the vascular channels, we can divide them as a capillary, small diameter vascular channels, and cavernous. large diameter vascular channels. Milken and Glavatsky described a biological classification based on endothelial cells characteristic, physical findings, and natural history that differentiates vascular lesions with endothelial cells proliferation, example hemangioma, from lesions with structural anomalies. It's vascular malformations. And here on this slide you can see various types of hemangiomas. Of course, on upper photos it's capillary hemangiomas, and the lower photos it's cavernous hemangiomas. Various diagnostic tools are available to diagnose vascular lesions, such as ultrasound with a color Doppler, CT scan, MRI, and MRI angiography. Management of hemangiomas is difficult due to the replacement of normal tissues by the diseased vessels and a high flow rate of recurrence. This management mainly consists of surgery, vascular embolization, or combination of both. Surgical treatment consists of wide resection, which is difficult and potentially hazardous due to the significant blood loss during surgery. The purpose of embolization is to occlude the vessels contributing the lesions. Various materials such as polyvinyl alcohol, gel foam, cyanoacrylate, metal coils, and collagen can be used for embolization. The combination of embolization and surgery is used to control acute hemorrhage, allowing for excisional surgery to be performed afterwards. And then we'll talk about precancerous lesions of oral mucosa. And here you can see classification of precancerous lesions. I'm sorry, not classification of lesions, it's a classification of causes. Precancerous lesions of oral mucosa, known as potentially malignant disorders, in recent years consist of the group of diseases which should be diagnosed in early stage. Precancer is a dynamic state that can transfer into cancer due to cancer's change in the cell's properties toward malignancy. Precancer to cancer transformation occurs not only by quantitative changes, time and weight, as a result of biological changes in cells specific for malignant cells, qualities, accumulations in them. Thus, precancer causes can be environment negative effects, exogenous factors, as well as whole body conditions disorders, endogenous factors, and as you can see it on slide. Exogenous factors, first, of course, it's a mechanical stimulants. For example, it can be bad habits. For example, keeping in mouse pencil, pens, and so on. Different kinds of poor quality prosthesis, fillings, manufacturing defects, abnormalities of bites, and dentition's defects. Chemical stimulants can be divided into two groups, household and occupational. Household chemical irritants include spices, highly concentrated solutions of alcohol, tobacco, and tobacco can be smoking and chewing. Spicy foods with lots of spices, which is widespread among the residents of the South, where the high-frequency leukokeratosis and oral cancer is observed. Tobacco has a roof irritant action to the mucous membrane of the mouth. Increased tobacco procedures usage leads to increasing patient quantity with leukoplakia and oral cancer. Occupational stimulants, it's alkalines, acids in the form of weapons, aerosols, and other chemicals depending on the concentration and action duration may lead to acute or chronic chemical injury. The temperature stimulants, hot food, cigarettes, burn sleeps, hot air during working in some enterprises. With prolonged exposure contributes to the precancerous disease's development. Meteorological factors, is an environment-negative agents complex that affects skin tissues and the face and lips. This includes the effect of sunlight, dust, wind, aerosol, salt water at low temperature and high humidity. Biological factors: yeast, peel, spearhead, chopstick cough, contributing the tongue, mouth, mucous membrane keratinization, embryosis, causing temporary infigment keratinization in some areas of the oral mucosa and increases tendency to malignancy. That was exogenous factors. And endogenous factors: anatomical and physiological features, increased keratinization, oral mucosa tendency due to its origin from the ectoderm. The tendency to keratinization increases with age due to cells dehydration. Hormonal changes, especially in women, influence the keratinization process, and some diseases of different etiologies, chronic anemia, diabetes, and others, can disrupt it. Listed above factors, both in isolation and together, are constant companions of human life and render permanent effect of oral mucous keratinization processes. Stress conditions, acute physical trauma value in the event of dyskeratosis appearing, for example, lichen planus, gastrointestinal tract diseases with chronic gastritis, enteritis, colitis, arising para or hyperkeratosis states, febrile states, and different etiologic serum stomias. And here you can see different types of classification of precancer lesions, and of course there are a lot of different types, and we'll talk about most simple and basic ones. Recently, a broad implementation in practice acquired precancer classification proposed by Hungarian authors Wenkel and Sugar, according to which all precancers are divided into obligate, mandatory, and optional. Optional precancers therefore divided into optional precancers in the broadest sense and optional precancers in the narrow sense. Precancerous conditions in the broader sense are characterized by the fact that the probability of their malignancy in below 10% of cases. This includes senile skin atrophy, chronic ray radiation, dermatitis caused by the action of the tar, arsenic scars, chronic inflammation including lupus, benign tumors, and others. To optional precancers in the narrow sense belong so-called xerostomias, senile keratosis, keratoacanthoma, cutaneous horn, and sores. Probability of malignancy at 20–30% of cases. Optional precancers are less likely to turn into cancer at a long exposure. Obligate precancers, processes which are with the greatest frequency transformed into malignant tumors in a relatively short time. To obligate skin precancers belong xeroderma pigmentosa, Bones disease, erythroplasia cara, and Paget's disease. Let's do a break and then we'll continue. Okay, we have a good rest and let's continue. Optional precancers with less potential malignancy. It's, as you can see on these photos, it's an oral mucosal chronic ulceration. Oral eosinophilic ulcer is an inflammatory disease of the oral mucosa featuring a painful ulceration with a tendency to heal spontaneously. This lesion is also known as a traumatic ulcerative granuloma with stromal eosinophilia. Both male and female are affected in equal frequency. The case and pathogenesis of mechanism of this disease remain obscure. Oral eosinophilic ulcer usually affect the tongue but may involve any other side of the oral mucosa. Clinically, it presents as a chronic ulcer with indurated borders that tend to persist for several weeks only to progress into remission, usually after a surgical procedure such as a biopsy. The biopsy procedure seems to alterate the healing process and is usually performed due to the resemblance of this lesion to carcinomatous ulcer. Then I'm sorry, I can't list the slide. Actinic cheilitis or cracked lips. Chapped or cracked lips in the term commonly used to describe dry lips. Chapped lips can be caused by several factors that include weather, excessive thickening of the lips, certain medications. Chapped lips are a common condition that only occurs for the most people, but some people may develop more severe from the chapped lips called cheilitis. Cheilitis can be caused by infection characterized by cracked skin at the corners of the lips. Actinic cheilitis, sometimes known as a farmer's lips or sailor's lips, is a precancerous condition related to the cumulative lifetime sun exposure. The lower lip is most often affected. Symptoms, as you can see on these photos, it's dryness, flaking, scale, sores, swelling, cracks, and bleedings. Lips don't contain oil glands like other parts of the skin. This means lips are more susceptible to drying out and cheilitis can occur. Lack of moisture can make the problem worse, whether indicated or related to lack self-care. Little humidity in the air during the winter months is known to cause actinic cheilitis. Frequent sun exposure in the summer can also worsen condition. Another common cause of chapped lips is habital leaking. Saliva from the tongue can further strip the lips of the moisture, causing more dryness. Chapped lips can usually be treated easily. The first step is to make sure that lips have enough moisture. And it's necessary to apply a lip balm that contains a minimum SPF 15 before heading outdoors. The balm helps to moisture the lips, and sunscreen minimize further drying effects. Drinking more water. Using a humidifier at home, avoiding cold water conditions, or wrapping mouth with a scarf. In some cases, plasma filling is necessary or surgical treatment if there is no any result of medicamentouse treatment. Leukoplakia is seen 6 times more among smokers than among non-smokers. Clinically, leukoplakia may affect any part of the oral and oropharyngeal cavity and can be divided into 2 subtypes, including homogeneous and non-homogeneous types. Leukoplakia plana is observed as limited needles of keratinization, different shapes and size, not increased above the surface of the mucous membrane. The surface can be folded grayish-white color, made sometimes around and needles may be inflammation. The most common localization, mucous membrane of the cheek, retromolar areas, and at least oral floor tongue mucous membrane of the lips. Non-homogeneous lesions have been defined as white and red lesions known as erythroleukoplakia that may be either irregularity, flat, or nodular. Verrucous leukoplakia is yet another type of non-homogeneous leukoplakia. Proliferative verrucous leukoplakia has a strong potential for malignant transformation and is resistant to treatment. Oral leukoplakia should be confirmed by mucosal biopsy, but before biopsy, some staining methods may be used as a diagnostic aid. The most commonly preferred treatment optional is a surgical excision of carbohydrate laser therapy. In widespread lesions, photodynamic therapy may be considered. Cryotherapy is another preferred distractive method. Non-surgical treatment modalities might be considered in selected patients. Carotenoids, vitamins, alpha-tocopherol, retinoid acids, for example, vitamin A, and bleomycin may be used in patients with oral leukoplakia. Surgical excision should be recommended in the presence of moderate and severe erythrophil dysplasia. And on this slide, you can see verrucous leukoplakia, and it's very difficult and severe disease, which in most cases in patients with some immunodeficiency states. Erythroplakia is defined as a fiery red patch that cannot be characterized clinically or pathologically as any other definable disease. Clinical appearance is characterized by a flat or even depressed erythromatous change of the mucosa without a patch lesion. Both red and white changes in the same lesions referred to as erythroleukoplakia. It mainly occurs in the middle-aged and the elderly. Male gender is most frequently affected. Most solitary lesions occurs over the surface of any part of the oral cavity, but the most commonly affected areas were responded as a soft plate, palate, and floor of the mouth and the buccal mucosa. Treatment is the same like leukoplakia. Next, it will be papillomas. Papillomas are tumors of the skin and mucosal surface formed by keratinocytes that have been transformed by human papillomavirus. Most of the skin lesions remain benign, but the mucosal lesions may be premalignant, and cervical cancer is an important sequela of HPV infection. Squamous papilloma, the most common benign epithelial neoplasm of oral epithelium. Squamous papilloma lesions may be found anywhere in the mouth with a predilection for the ventral tongue and frenulum area, palate, and mucosal surface of the lips. Oral papillomas can be recognized by their small finger-like projections, resulting in exophytic lesions with a roof or cauliflower-like verrucous surface. These lesions often have a wide appearance and can occur in any age group. Squamous papilloma lesions are thought to be indicated by HPV 6 or 11. The type treatments is surgical excision, of course. All lesions resembling a squamous papilloma are recommended for excision at the base 1 to 2 mm margin to the depth of the submucosa. Removal should also be considered and cure. Recurrence of the or appearance of a new lesion suggests a possibility of retransmission of a condyloma, accumulation of a carcinoma. And here on the slides you can see different types of removal of papillomas. It's a cryotherapy, surgical removal in different ways, and laser, using laser. Cutaneous horn, it's a very strange disease. Cutaneous horn is a projective, conical, dense, keratotic nodule that resembles the horn of animal. The horn is composed of compacted keratin. A number of skin lesions can be found at the base of this keratin mound. Cutaneous horn most frequently occur in scenes that are exposed to actinic radiation or burns and hence are typically found on upper parts of the face. Other locations include scalp, nose, eyes, ear, lips, chest, necks, and shoulder. Over 60% of the lesions are benign, however, malignant or premalignant lesions might be associated with it. Histopathological examination of the base of the lesion is necessary to rule out associated carcinoma and full excision of the treatment of the choice. In general, malignant or premalignant conditions are more common in older male patients, especially when the cutaneous horn is found on the face. And of course, treatment is a surgical removal of this cutaneous horn with histological examination. And then a few words about obligate precancer skin diseases. Xeroderma pigmentosa, the most mode of inheritance is autosomal recessive. In the event of illness, there is important role of the blood collagen parents and innate sensitivity to sunlight. The skin of patient is extremely sensitive to sunlight and its changes lead to malignancy. Clinical picture, 2-3 years old children get redness, peeling, dryness of open areas of the skin, face, necks and head. Face, neck and hands in the spring and summer. There are swollen erythematous areas without clear separations after exposure to the sun. It is formed the pigmentation as a lentigo and freckles after the dissolution of erythema. In superficial pigmentation appear white atrophy, telangiectasias and keratosis. Number of pigmentation increases, the skin becomes colorful and areas of atrophy can cause atresia of mouth, ectropion. It's a medical condition in which the lower eyelid turns outwards. In addition, skin lesions are accompanied by conjunctivitis and photophobia. Atrophic changes lead to a thinning of the ears and nose, loss of eyelashes. The aortic growths develop from keratosis that eventually transformed into epithelioma and sometimes sarcoma and melanoma. Neoplasms can metastase to internal organs. In addition, bone dystrophy, microcephaly, retarded physical and mental development are noted at these patients. Most patients die before the age of 15. Treatment, bracing therapy, and preventive measures, maximum restraint from solar and ultraviolet insolations. Skin cancer. Cancer of the oral cavity is one of the most common malignancies in the world. Squamous cell carcinoma is the most common histologic and main etiological factors are tobacco and alcohol use. Also, early diagnosis is relatively easy. Prevention with advanced disease is not uncommon. The standard of care is primary surgical resection with or without postoperative adjuvant therapy. Improvements in surgical techniques combined with the routine use of postoperative radiation or chemoradiation therapy have resulted in improved surgical statistics over the past decade. Successful treatment of patients with oral cancer is predicated on multidisciplinary treatment strategies to maximize oncologic control and minimize impact of therapy on form and function. Alcohol and tobacco seem to have a synergetic effect in etiology of oral and oropharyngeal cancer. However, alcohol is linked to increased risk of cancer even in non-smokers. Other factors such as a poor oral hygiene, wood dust exposure, dietary deficiencies, red meat and salted meat consumption have been reported as etiologic factors. Host factors such as immune system alterations in transplanted patients and HIV-infected patients with AIDS and genetic conditions like seroderma pigmentosa, Fanconi anemia, and associated with the increased incidence of head and neck cancer. Squamous cell carcinoma constitute more than 90% of all oral cancer. Other malignant tumors can arise from the epithelium, connective tissues, monosalivary glands, lymph node tissues, and melanocyte or metastasis from a distant tumor. Despite easy self-examination and physical examination, patients often present with advanced stage disease. A comprehensive head and neck exam is mandatory in patients with suspected oral cavity cancer. Visual examination or inspection and palpation allow to accurate impression of the exact of disease, and third, diminish of tumor, the presence of bone invasion or skin breakdown. Although the typical patients with cutaneous squamous cell carcinoma is often Northern European descent and patient with a family history of the skin cancer, a personal history of previous skin cancer, and or extensive history of sun exposure. Presence with a wide variety of clinical manifestations, including papals, plaques or nodules, and smooth hair hyperkeratotic or ulcerative lesions. And you can see these lesions on photos and slide. The clinical stage of tumor should be recorded at first encounter and modified as evaluation progresses. The initial worksheet consists of diagnosis by biopsy. Some patients will require examination under general anesthesia in order to assess posteriorly located lesions or to complete a physical exam limited by pain and trismus. Radiographic imaging is crucial for evaluation of the relation of the lower of the tumor to adjacent bone and for assessing regional lymph nodes. CT scan is the study of choice for evaluation of the bone and neck nodes, especially early cortical involvement and extracapsular nodal spread. MRI provides complementary information about soft tissue extent and perineural invasion, and is also helpful for evaluating the extent and medullary bone involvement because adult marrow is normally replaced by fat. Most patients with oral cancer are not at risk for distant metastasis, and therefore the role of PET scan in initial assessment is debatable. And surgical treatment or surgical resection in the treatment of choice for different types of these cancers. It allows accurate pathological staging with information about the status of margin, tumor spread, and histopathological characteristics, which can then be used to inform subsequent management based upon assessment of risk versus benefit. Adjuvant radiotherapy with chemotherapy is used for specific indications in the local regionally advanced tumors. Multidisciplinary team is absolutely essential to ensure a favorable outcome. Multiple factors are taken into account of selection treatment for individual patient. The risk of treatment-related complications should be assessed based on physiological age, comorbid conditions, lifestyle, surgical resectability, and patient expectations. And here you can see stages of reconstruction or surgical treatment of patient with cancer of the lip. And you can see on photo C flaps planing, and D it's a reconstruction after a year after operation. Basal cell carcinoma is a non-melanocystic skin cancer that arises from basal cells. It's a small round cells found in the lower layer of the epidermis. The prognosis for patients with basal cell carcinoma is excellent, but if the disease is allowed to progress, it can cause significant morbidity. Signs and symptoms you can see on these slides. Approximately 85% of basal cell carcinomas occur on the face and head, and more rarely in neck. Others appear on the trunk or extremities. Rarely, they may occur on the hands. Waxy papules with central depression, pearly appearance, erosion of ulceration, bleeding, oozing of the or crusted areas, rolled borders, translucency, telangiectasis over the surface, and slow growing from 5 millimeters in 1 to 2 years, and black, blue, or brown areas. Different types of basal cell carcinoma, and we can divide it into nodular, infiltrative, microgranular, morphiform, and superficial. Diagnosis, given that basal cell carcinoma rarely metastasis, laboratory imaging studies are not commonly clinically indicated in patients present with localized lesions. They may be necessary with involvement of deeper structures such as bone in clinically suspected. In such cases, CT scans or radiography can be used. Histologically, basal cell carcinoma is divided into two following categories. It's undifferentiated and differentiated. And of course, treatment, it's usually surgery. In surgery, we can use excisional surgery and radiation therapy and cryosurgery. And here you can see clinical features or clinical pictures of basal cell carcinoma. It looks like some spots in the face with different colors from red to brown. And as I said earlier, it grows very slow. And that good information that it's rarely metastasis. Here you can see on the slide different types of skin tumors. Normal mole, actinic keratosis, dysplastic nervi, basal cells, squamous cells, and melanoma. And then let's talk about types of biopsy, because it's very important information. We can use different types of biopsy. Tissue or cell samples can be taken from almost any part of the body. However, samples are taken depends on where the tumor is and what type of cancer is suspected. Needle biopsy, there are two types of needle biopsy. It's a fine needle biopsy, also called as fine needle aspiration, and core needle biopsy, also called core biopsy. Fine needle aspiration uses a very thin hollow needle attached to a syringe to take out a small amount of fluid and very small pieces of tissue from the tumor. The doctor can aim the needle while filling the tumor if it's near the surface of the body. If the tumor is deeper inside of the body and can be felt, the needle can be guided while being watched on an images test such as an ultrasound or CT scan. The main advantages of fine needle biopsy or aspiration are that the skin doesn't have to be cut, and in some cases it's possible to make a diagnosis the same day. The disadvantage is that sometimes this needle can't be remove enough tissue for definitive diagnosis. Core biopsy needle used in a core biopsy are slightly larger than those used in fine needle aspiration. They remove a small cylinder of tissues. The core needle biopsy is done with local anesthesia. Like fine needle aspiration, a core biopsy can sample tumors that the doctor can feel, as well as smaller ones that most be using imaging tests. Processing core biopsy samples usually takes longer than fine needle biopsies, so getting the results of those tests also might take longer. Excisional biopsy. In these types of biopsy, surgeon cuts through the skin to remove the entire tumors, called as excisional biopsy, or a small part of the large tumor, called as incisional biopsy. This is often done using local anesthesia. Punch biopsy is considered the primary techniques to obtain diagnostic full-thickness skin specimens. It's performed using a circular blade or trepine attached to a pencil-like handle. The instrument is rotated down through the epidermis and dermis and into the subcutaneous fat. The punch biopsy yields the cylindrical core of the tissue that must be gently handled, usually with a needle, to prevent crush artifacts at a pathologic evaluation. And a few words about tumor-like formations. They are not tumors. Also, they are similar to tumors by visual evaluation and anamnesis morbi, but the main difference is the absence of abnormal self-proliferation and changes. Most simple example is atheroma. Atheroma is a tumor-like formations which occurs by increased sweating of the sebaceous glands and forming of the capsule around the mentioned fatty content. Atheromas are placed in the last layer of the skin, dermis, and their other name is a dermal cyst. It forms by clogging the sebaceous gland duct, which in turn causes the sebum to accumulate in the gland itself and around it. A membrane capsule then gets formed around the accumulated sebum, containing it and preventing it from further expansion. Symptom and signs, as you can see on these photos. The first thing that is noted is a painless bump in the skin, and the most common regions are head, face, neck, and chest. It can become inflamed very often. It then turns red, painful, and swollen. Inflammation can sometimes resolve by itself, but more often it will become a purulent infection, which can then be addressed only surgically. Diagnosis is easily acquired by visual examination and by palpation in order to assess the hardest and size of the lesions. The biopsy is rarely needed. If it doesn't cause any discomfort or aesthetic problems, it doesn't even need to be treated. But if it gets infected, it's necessary to surgically address the issue in some of the following ways: incision, excision, and punch method. Thank you for your attention. Of course, there are a lot of information, and I understand that it's difficult to understand and to remember, but I hope that you remember some of this information: types of tumors, odontogenic and non-odontogenic tumors, and tumor-like formations. We'll see on practice classes. That is all. Thank you for all of you, and goodbye.